هلا، السلام عليكم دكتور فارس.
عليكم السلام، أهلا وسهلا.
كيف حالك؟ تمام.
الحمد لله. Thank you for the invitation.
ثانك ان شاء الله هنبدا الساعه 8 بالضبط ان شاء الله.
For sure, for sure. يلا I'll wait 12 minutes. Yeah.
Is the audience can hear us or no? الو.
We're waiting for somebody from the audience to respond.
طب احنا على الزوم وبنعمل بروجكشن لليوتيوب ان شاء الله.
Uh, yes. Let me, excellent. Let me check now the share folder. Shall I share already? It's disabled. Can somebody open the sharing for me?
I think they are might not be there yet. I don't know.
So host disabled participant screen sharing. Probably they're not hearing me.
Hello, Dr. Forrest. Can you try to share now, please?
Thank you very much.
Who's with us tonight? Hello.
You're talking to me?
No, the Pearl. Who's from
Share
Pearl
now.
with us?
You're with Jess, Dr. Tawakol. Hello?
Yes.
Yes. How are you?
You're
It's been
seeing
a
me?
while.
Good. The audience, did you allow them to, are we online or still not online?
We are already on live, Doctor. So we already have 159 on the line. So you just need to share your presentation and
My
let's.
presentation is shared.
Yeah, but we will wait until 8 o'clock because we announced for 8 o'clock.
Yeah, but did you see my presentation?
Yeah, it's there. Yeah.
Thank you.
Jess, are we ready?
Yes, we're ready when you're ready, doctor. We can start at 8. 1 minute more.
السلام عليكم. بسم الله الرحمن الرحيم. I'd like to welcome all of you for our new virtual track. As we are used to, we try to do this meeting quarter annual. This meeting actually, I have been waiting for a long time. It's a new field of neonatal experience. about the monitoring of newborn babies. This is a new, I would say, aspect of how to monitor our sick babies in the neonatal period. Today, of course, I'd like to welcome my dear colleague and dear friend, Dr. Faris Shadid. Me and Dr. Faris Shadid actually been knowing each other for probably the last 12 years since I came here to UAE. Dr. Faris Shadid used to be a senior consultant at Tawam Hospital, and then currently he's the head of the neonatal department at Kanat Hospital in Al Ain. Dr. Faris, beside his topic, whatever he's gonna talk to us tonight, Dr. Faris has a lot of experience also in evidence-based medicine, and I actually enjoyed his talks in this field too. Before we start our meeting, I would like to tell you about other forums. We have our monthly online grand round, and we have the physical ventilation course, which will be in Abu Dhabi in January with advertising on the Pearl webpage. So again, I'd like to thank Pearl Management, Mr. Muwaffaq al-Shimali and Jess, who are both of them are organizing this event tonight. Now let's start with Dr. Faris, and Dr. Faris tonight will talk to us about waves and histogram and trends of vital signs in the newborn. Thank you, Dr. Faris, for joining us, and the floor is yours.
Thanks, Dr. Hisham, and greeting to everyone. I will also greet my daughter in the US who's attending now. So good morning, Crystal. My talk will be on waves, histogram, and trends of vital signs in the newborn. Trying to go down. I have no conflicts of interest. And my talk will be very simple. It's what we use every day at the bedside. I will look at the heart rate, saturation monitor, invasive blood pressure monitor, and respiratory wave. All of these, I will look at them from a three-point perspective: the waves, the trends, and the histogram. At the same time, this same wave could be used to to assess the perfusion. With the invasive blood pressure, we can assess the pulse pressure, and with the SpO2 plate, we will assess also the perfusion index. I'll be talking about all of these. It's quite a big subject. It will take about 45 minutes, but it is only pictures, and all pictures were taken from the bedside monitor. So I'll start with the heart rate wave. Nothing much to talk here about it, but the heart rate histogram. And what is the histogram for? The histogram is to tell us what % of the time a patient was within target. Like this is a very preterm or extreme preterm. The heart rate target would be 100 to 180. And I see that this patient was 98% of the time within target and very rarely out of target. Okay, so the trends also will allow us to see how it is progressing over time, and both will show us when we do any intervention, what is the effect of our intervention. So here is a histogram of blood pressure, of heart rate, and the trend of the heart rate. There is another type of trend, but it's out of the scope of this talk. It collects from the cardiac monitor, and it's called the hero scoring. They look at, antenatally, the obstetrician, every time they call us, they tell us, well, we need to call you because there is decelerations, there is accelerations, there is lack of heart variability of the baby. So they're looking at all those parameters before birth. But after birth, we simplify it and we only check the heart rate and the waves. But the hero monitoring, it will look at that variability and entropy. And when there is less variability, less entropy of the heart rate, they give you a score, an odd ratio score for sepsis. And anytime the odd ratio is above 2, it goes all the time. You can see the odd coming up. And like in this patient, in here, the odd increased from 1 to 3.51. From below 1 to 3.51, it doesn't mean like we start antibiotic, but it means that we need to go assess that baby and see if anything we're missing. So, but this is not within the scope of my talk. So I finished with the heart rate wave histogram and trend. Now I will go in another subject that's more helpful also at the bedside, that is the saturation histogram and trends. Here is a baby who's 24 weeks, 600 gram, 10-day-old. He had a significant PDA, pulmonary edema, and also got infected with a severe neck, as you see here. So we look at the histogram, and this is very interesting, you know, like we would like it to be between 90 and 95 most of the time, but we can see that the patient was within target only 52% of the time, and difficult to manage because what we will act on, because he's desaturating below 90, 35% of the time, and having hyperoxemia 23% of the time. More important, the amount of desaturation below 85 was quite important. Consider above 10 to 15% quite important. So it is very informative, and this was a 12 hours histogram. So 12 hours histogram, that means every 1% is 7.2 minutes. 1/3 of the time, 4 hours, he was desaturating, and 1/5 of the time he was oversaturating. So it is very informative to see, and sometimes we do it every 2 hours or every 4 hours, every 6 hours to check. When you check it, when you do any intervention or any weaning, you could say, please do me the histogram after 4 hours to see if the patient liked what I did. Now, the SpO2 trend is also very relevant, because look at here the bedside monitoring by the nurses. The nurses are really capturing the desaturation. They're telling me that was 3, 6, and 2, 8 desaturations. But many publications have shown that what the nurses record is much, much less than what's happening. You see here in the same period, there are many, many more and very deep desaturations sometimes. What the nurses also don't capture is the hyperoxemia. We see that this patient above 95 also went so many times. No nurse at the bedside will record that the patient had hyperoxia. They will record only apneas and desaturation. So if you question the trend, we look at the trend every morning ourselves, and our nurses report every morning the 12 hours histogram of the previous shift. So when we look at this patient, we clearly know that he is out of range lots of the time. This is another patient. No, this is the same patient, but when he got older and healthier, he was 30 days old, was on nasal CPAP, wasn't receiving any oxygen, and his saturation was all the time above target. Except that from 12 o'clock, he started having desaturations, a cluster of desats, and that monitoring will clearly help you to know that something is happening. There was here a mucus plug. We did deep suctioning, and the patient normalized fully after that. So, but again, here I have 4 desat by the nurses, while the patient had maybe 10 desat or 8. SpO2 histogram is more helpful when you do it at the same time with the respiratory rate histogram. Here is a patient, 26 weeks, 900 grammer. He was receiving only 1.5 liter per minute low flow nasal cannula and 21% oxygen. When the patient is on 21% oxygen, we don't mind what percent of the time he's above target, because when he's in room air, he will not have 400 of PO2. So I would say he was normal all the time. Only 2% of the time he was having some desat. So we are very pleased with that baby from saturation point of view. But look at the histogram for respiratory rate. The histogram for respiratory rate, he was breathing between 60 and 80, 38% of the time, another 4% of the time above 80. So this patient is clearly having tachypnea without desaturation. And you say, maybe I don't need much oxygen, but I need to increase the flow from 1.5 to 4 liters per minute for a while, till he shows me improvement of histogram. Then I wean while watching the histogram. And this patient was anemic, but not enough to get transfusion. So this is a case of tachypnea without desat. Certainly, when there is tachypnea, it merits that we go assess if there is with the tachypnea distress. We don't want the effortless tachypnea to be overinterpreted. Another patient here has the opposite. He has desaturation but without tachypnea. This is a 25-weekers, now he's 32 weeks corrected age. He's receiving minimal oxygen, 23-25% oxygen, but very relevant that he has a ROP stage 2 zone 1. It's near threshold. So we don't want hyperoxia, and certainly we don't want hypoxia because hypoxia will increase the ROP. Well, this patient was only 50% of the time within target, was having 50% of the time above or below target. So you look at the histogram of the respiratory rate, he wasn't in any distress. We see that between 20 and 60 all the time, nothing above 60. So this patient has hypoxemia that need to be acted on. Difficult. Sometimes we do everything we can and we remain with the same. But we adjusted caffeine dose, treat anemia to increase oxygen carrying capacity, and we put that baby on automatic control of oxygenation. And certainly when you have hypoxia, it's not as relevant as if you have hypoxia to the brain. So you put I don't have the near-infrared spectroscopy in my hospital, but you would have to put a near-infrared spectroscopy to see if the brain is affected by that hypoxia. I'm nearly finishing with the respiratory rate histograms. This is a typical patient with transient tachypnea of the newborn. This slide, this one, I took it from Professor Yasser Said. So this transient tachypnea of the newborn, he was breathing above target. This is respiratory rate histogram for 24 hours. Above target, he was breathing 3/4 of the time. So 3/4 of 24 hours, he was puffing and breathing fast. But that was 24 hours later. That was the first 24 hours. And even above 80 per minute, he was breathing severe tachypnea, 45% with some distress. Now, 1 day later, we see clearly on the histogram his improvement. So it helps you judging how quickly you would wean. Now he's breathing not anymore anything above 80, 0%, and some mild tachypnea. Most of it is in the 60 to 70, nothing much in the 70 to 80. So this patient clearly is showing an improvement, and 24 hours later, breathing only 1% above target. So this patient is ready for quick weaning as TTN do, and based on histogram. And watch on the effect of your weaning with histogram. So a question, what does an optimal saturation histogram looks like? So if your patient is having oxygen more than 23, 24% oxygen, you would like the SpO2 to be within target because you don't want hypoxemia, and certainly SpO2 above 96 could be normal or could be 400 of PO2. So a patient receiving an amount of oxygen more than 25% or 25%, you would like to keep him within target of 90 to 95. But a patient who is, because it was shown in the study of stop prop that hypoxemia decrease ROP, but hypoxemia will decrease ROP, but will increase mortality, different from what's written here. So when the patient is not on any oxygen, the optimal histogram would be shifted totally to the right, you know. It could be within target from 90 to 95, but anything above 90, 99, 98 is a good SpO2 for a patient who is not having oxygen. So to close on the respiratory and SpO2 histogram, it can be used for deciding how to escalate or de-escalate a treatment. I will not go in detail with this because it will take time. But I would say we look at the respiratory rate at the same time with saturation. If the patient is having less than 20% of respiratory rate below 60 to 80, We call it no tachypnea or minimal tachypnea. Above 20% of 60 to 80, moderate tachypnea. But when we start to have above 20% of above 80, it's a tachypnea, especially once associated with increased work of breathing. With that, the table is dividing DSATs between below 20%. There is no literature about that to make a cutoff and say below 20% DSATs, it's safe. No, but because it's quite common, and that's an expert opinion, they say you might have a DSAT up to 20% because the brain has ways to defend himself, and especially if you have NIRS to check that the brain is not affected. So if you have below 20% of DSAT and maybe below 10% of DSAT below 85, it's acceptable. We are in the green zone initially here. We could start weaning. If you have above 60 to 80, you may to wean or keep the same. Now, if you are in the red here, where you are breathing very fast above 80, you increase support, and when you have DSAT, you might increase oxygen, and you have those gray zone where you decide what to do based on how much hypoxemia and how much tachypnea. You can use it also dependent where you start from. If your patient is an IPPV, CPAP, or high flow, and you want to escalate based on histogram, you go by steps. You want to wean, you go by steps, no rush, and you keep doing histograms as you wean. And then you might escalate also by steps and do histograms as you escalate. So I finished now with the not half, but two parts of my talk. Heart rate, waves, histogram, and HERO monitoring a little. Then about SpO2 and respiratory rate, we spoke. Now, I would like to introduce two important messages. Both of them, they come from the waves. The perfusion index will come from the SpO2 wave, and then the pulse pressure, which is the difference between systolic and diastolic blood pressure, will come from the invasive blood pressure wave. So we are gonna ride the waves with you. If this baby can do it with a bottle in his mouth, we probably can do it. So we'll go to compare and see what is perfusion index and pulse pressure. The upper wave is the blood pressure. The lower wave is saturation wave. For the saturation wave, there are 4 lines, as you can see here, 2 lines in the middle and 2 lines periphery. For the perfusion to be sufficient and the monitoring to be correct, you need at least the wave to touch the 2 middle lines. That's acceptable perfusion. Good perfusion is a little more. Low perfusion, or maybe the probe is moved a little. Poor perfusion when you didn't touch the 2 lines, and artifact. So you will watch on those well before interpreting. Then, what is a perfusion index? The saturation monitor has 2 functions. First function is to measure the saturation, oxygen saturation. To measure the oxygen saturation, it sends 2 infrared wave. One infrared wave will measure oxyhemoglobin. The other infrared wave will measure deoxyhemoglobin. And they make a proportion, and they tell you what is your proportion of saturation, which is SpO2. That is one function which we discussed. Now, the other function is a plethysmography. It has nothing to do with measuring the saturation. Like any plethysmography, it measures when the blood reaches to the finger or to the ear or wherever you're putting your saturation monitoring. When the blood moves through the arterioles, it will bulge those arterioles. That bulging of the artery is transformed by the saturation monitor into an electric current. So you have the alternate current, alternate because every time you have a systole, you get a bulge. And direct current when you don't have a systole. They correspond to systole and diastole. Now, if you have high perfusion, you will have the AC higher. So the perfusion index equal the upper value divided by lower value times 100. So that's the perfusion index. It's measured in every single patient in your unit with a saturation monitor. You can go and ask the saturation monitor what is the perfusion index, and you might ask also to give you a histogram of the perfusion index. Doesn't need all my talk doesn't need any intelligent machine except our intelligent monitor. Now, in parallel, the blood pressure monitor, you see that the wave goes from diastole it will reach to systole, top systole, but still in systole, but at lower flow. And in here, there is decrotism. At the site of decrotism, there will be the opening of the closing of aortic valve. And then diastole starts, which takes a slightly longer time than systole. So diastole starts from the decrotic time, it will reach to the lower part, which is the diastolic blood pressure. So the systole is before the decrotism and diastole after the decrotism. So the difference between systole and diastole is equal to the pulse pressure. So the pulse pressure is a bit the same idea as a perfusion index, but more precise to measure. You see the decrotism also present in the SpO2 monitor. So this is what it is for each of them. Let's see how they help us at the bedside. This is a normal perfusion index, histogram. So again, we can go to the histogram and we can request as many hours as we want. This was a 12 hours histogram. And the normal value is between 0.4 and 3. Like when you're doing your CCHD screening, the critical congenital heart disease screening, you should have a monitor with ability to measure perfusion index, because if your perfusion index is less than 0.4, your screening is incorrect. Anyway, the normal perfusion index is between 0.4 and 3. And ideally, your histogram should be compact together and somehow in the middle. So in this patient, it's totally normal with only 1% increased circulation, no problem. Now, this morning, I took this picture from a 22 weeks and 6 days baby in my unit, 440 grams and 5 days. I thought, let's look at the histogram. The baby is beautiful, feeding now, progressing feeding, and normal for now with ventilation. So the perfusion index slightly shifted to the right, not much, but it's above the 0.4 and below 3, so it has a normal perfusion index. So let's see how can we use it. I'll give you three interesting cases of perfusion index. This was one of our patients maybe 7-8 months ago or more, with right lung agenesis, and then get a complication later on, which is left lung pneumonia, and got septic shock. So for the septic shock, is now 20 days old septic shock. We treated it as usual because septic shock with the 2 volumes, and we increased progressively up the epinephrine to high dose and norepinephrine also. With that, we're very happy. His mean blood pressure went above 80, and then it was between P50 and P90. So you could say, well, we're winning. Let's let's go sleep, let's go rest, because our blood pressure is normalized with our treatment. So I went and requested a histogram for the perfusion for this baby. And unfortunately, this baby who looked so well with the blood pressure, but I was having too much alpha effects with epi and nor-epi higher dose. And then, yes, I'm seeing good blood pressure, but here his perfusion is below normal in 41%. And maybe this one also is abnormal, because every baby has its normal value, but at least the whole histogram is shifted to the left. So clearly this patient is telling me, yes, you improved my blood pressure, but you deteriorated, you destroyed my perfusion. So here, we stopped epinephrine and we decreased norepinephrine, and beautifully, within short period of time, the histogram shifted to the right and was within normal. So it's important when you are having hypotension, since in every baby a perfusion histogram is available, any patient who's having a hypotension, we don't treat it without checking the histogram of the blood pressure and the histogram of the perfusion index. This is a baby who is now in my NICU, and he's probably now 16 days old, whatever, but now he had neck, 24 plus 6 weeks, 670 grams. On day 8 of life, he had necrotizing enterocolitis, quite severe one, and the shock. So the patient blood pressure was increased to above percentile 50. As you notice here, I'm talking percentile, I'm not talking value. Many of us use gestational age or gestation age plus 3 or gestation age plus 6. But since we have histogram of blood pressure, we should aim for a blood pressure between P5 and P50 for every patient. There is no one single value. So this patient was having, and we should start weaning when the blood pressure is above 50. So this patient, his blood pressure went above P50 with dopamine 18 microgram, norepinephrine 0.1. Since I was doing the talk also, I wasn't on call. Unfortunately, the patient with this severe neck, he had an acidosis of -16. It could be due to the neck. But with that acidosis, I called the specialist in the hospital. I said, can you take a picture of the histogram and send it to me? And then this is what she did. The patient blood pressure is above P50, percentile 50. It's totally normalized with dopa and epinephrine and norepinephrine. But his perfusion index is not below 0.4, but it's clearly totally shifted to the left. And this patient is having acidosis, possibly partly related to the fact that he's having too much alpha effect. So I asked her to please decrease as quick as you can the norepinephrine. And then the histogram started to shift to the left, to the right. And then we stopped norepinephrine, and we're down now from 18 mic of dopa to 5 mic. We're beautifully shifted to the right now. And then when we get to 2 mics of dopamine, now we are totally in the middle. It is so clear and so evident that the perfusion index is relevant in the treatment of shock. Another patient, you will not find any Cochrane today or any p-values or anything. It's only picture after picture. So this patient had chronic lung disease and pulmonary hypertension on sildenafil. Out of interest, I thought, let's go check this histogram. And then I found that because sildenafil is a vasodilated, 11% of the time, the values were above 3. Showing that he's vasodilating. If this patient wasn't, I don't remember him, he's 2 years ago. So this patient, if he was deteriorating while on sildenafil, it could be that we're opening the wrong vessels of the lung and increasing the shunt. But so this is good to do the histogram when you're on a vasodilator. This is from a publication in 2018. Interesting publication. It shows also in severe hemodynamically significant PDA, you might have decreased mean arterial pressure. But as you know, we have a bounding pressure because the systolic becomes high. And if the systolic is high, it means like we will have a higher perfusion index. And that's what Dr. Nidzan in this publication showed. He showed that in hemodynamic significant PDA, 44% of the time, the perfusion index was above normal because it was bounding pulse. And then when they closed the PDA, now the pulse, the perfusion index is within normal. I have still 2 more cases to discuss about, or 1 case, and then we'll go to the blood pressure monitoring. So interesting, this case about how to diagnose hypovolemia with the wave. So normally our wave that we see on our monitor for SpO2 runs at 25 millimeter per second. If you push on your finger on that SpO2 on the blue graph, it will open you the choice to say what speed you want. You can go from 6.25 to 50. So you go and request less speed. So if you have less speed, you'll have many more, like an ECG, it becomes the SpO2. And that's a normal SpO2. So the patient is ventilated here, the PIP and PEEP, but it's not affecting at all my SpO2 wave. But if the patient is hypovolemic, you will find that every time you have an inspiration, your perfusion index will decrease. Sorry. And then that variation due to PIP would be caused often by hypovolemia or by increased intrathoracic pressure. So next slide will explain it very easily, why it happens like you have that variation with hypovolemia. That's with the Frank-Sterling curve. It shows here the Frank-Sterling curve tell you what's your stroke volume based on your preload. If your preload is high, your stroke volume will not be affected anymore by your preload. But if your preload is low, you are at the exponential part of the curve, you are much affected by the preload. So this patient here, when he has hypovolemia, the PIP of the ventilation will put him down here. And then his volume will keep going during expiration up here and down here. So that you see, this is during inspiration. He will have less venous return and less perfusion index. And during the expiration, it will be bigger. So that's a sign of hypovolemia or increased thoracic pressure. So I finished now with everything related to SpO2, including the SpO2 trend waves and anything that goes with it. Now we reach to another part of my talk, which is the invasive blood pressure wave. And I don't know, I never looked at it, but I learned it late. I will start looking at it. It's called the pulsus bisfrians of hemodynamic significant PDA. It seems like it's 100% specific for hemodynamic significant PDA. When it's not hemodynamic significance, you don't find it. What you will see, bisfrians means double, frians mean double peak. So normally this is how it looks, the graph of invasive blood pressure wave. But in PDA, you will have one peak here and one peak here, one peak here, one peak here. You look at the graph here, you might not see it well, but there is some two peaks here. And why would you have the two peaks in hemodynamic significant PDA? Because normally we think that during the stroke volume, during systole, the pressure will go from diastole to systole. No, what happened during systole, the pressure will go somewhere near the peak here. But that flow that goes to the periphery, and as it goes to the periphery, it will find higher and higher and higher resistance. There will be a reverberation or a return of pressure that will create this second peak. So this peak is created by the stroke volume, and this second peak here, but they are joining each other, so you don't see two peaks because they join in each other. But the second peak is due to return of pressure due to high resistance from the periphery. So when you have a PDA, that because of the bounding pulse, that peak will shoot up. So you will find two peaks and the hole in the middle. So it is shown here in this beautiful publication by M. Grevers. He says this is how it goes the wave normally. And when you have a patient with hypertrophic cardiomyopathy with the differential diagnosis, hemodynamic significant PDA, hypertrophic cardiomyopathy, or regurgitation in the aorta, anything that causes big flow during systole, you would separate the two peaks. Then you have two peaks. So this is a differential diagnosis. So now, if you're still with me, so we spoke about invasive blood pressure monitoring. We reach now to the last part of my talk, but it will take some 15 slides, I think, quick ones. The blood pressure histogram and trends. So now that we jump on top of waves together, let's go in a histogram hike for the blood pressure. This is a picture I took this morning from one patient, 25 weeks, 620 gram, day 5 of life. And that's his blood pressure. So what would be the blood pressure that you want for that patient? You can take this one, it's easy, read it here, blood pressure dash neonate. If you press on this one, it will give you the blood pressure for the first week of life. You just fill simply station age 25 plus 1 and postnatal age day 5. You get percentile 2, percentile 98, percentile 16, because this is z-score -2, -1, 0, +1, and +2. and that baby blood pressure should be, the target should be between P5 and P50 somehow. And then above P50, you would wean, and below P50, you check if there is need for support based on his acidosis, urine output, and everything that goes with it. So this is a way to check. When you check, and every baby should have, whenever we have an issue, question about blood pressure, the nurses should go directly to the swab site, and they will look at the blood pressure, and they will do the histogram based on the blood pressure. They tell you which one is within target, above target, below target. So we don't look only at the same patient here. We don't look only at the systolic blood pressure. We should look at diastolic and mean blood pressure. Now, the next 7 slides, I'll have to announce it. The next 7 slides or so will be are all from Dr. Yasser Sayed, Professor Yasser Sayed from Manitoba, and he was kind to allow me to use them, but I believe they have copyright. So if you're copying my talk, I'm happy with that, but please don't use those slides without his permission. So the next 7 slides, I took them from him, thanks to him for giving me permission. So these were my patients here with you can have a percentile for mean, systolic, and diastolic. Look at this patient. This is from Dr. Yasser Sayed. He has, I'll have to ask him to give me that. He has percentiles 5 percentile, 50, and 95. Well, I have a different percentile. Anyway, this patient was 30% below target. It's quite relevant that 30% below target, and not much above target, only 5, 4, 9, whatever. So he is having hypotension. When you look at it, this is why it's relevant to look at the systolic, diastolic, and mean. We see that the systolic is only 30% below target, while diastolic is normal, not much below target, and the mean is not much below target. Even so, the point is in this patient that the diastolic blood pressure is an expression of systemic vascular resistance. So this patient is not having vasodilated shock or vasoconstrictor shock. His diastolic blood pressure is normal. But the systolic blood pressure depends on the stroke volume. So this patient is not having any problem with vascular resistance, but he has an issue with stroke volume. It expresses to me, most probably, that he's having a cardiogenic shock. If he's an extreme low birth weight infant, it's a classic. That's the most common shock they have on day 1, day 2. So this patient would need low-dose epinephrine or dobutamine. He wouldn't need dopamine or other vasoconstrictor because he's not vasoconstricting. This is the benefit of looking at the histogram, the 3 of them at the same time. So we spoke histogram, finished. Now I will have a few slides on the SpO2 trend, not SpO2 trend, blood pressure trend, and then specifically the pulses pressure trend. So as you see, this is a systolic, diastolic, and mean, and the pulses is pressure is difference between systolic and diastolic, the gap between systolic and diastolic. Very easy. You can see the trend here. The upper line is the systolic, the middle line is the mean, and the lower line is the diastolic. So you can see them coming in a trend, and you can move that cursor anywhere. You could read everywhere you put the cursor, any place, you will read the blood pressure corresponding to the place where you put the cursor. And you can see your trend that's not moving down or up. So this patient is not going, you wonder if anything happening here, but it doesn't seem to be any problem. So this is the difference between systolic line and diastolic line is your perfusion pressure. Okay, so it's simple. Let's look at the blood pressure, the pulse pressure, not the perfusion pressure, the pulse pressure in a more, slightly more complete way. The pulse pressure is equal systolic minus diastolic. We learned that the diastolic pressure is caused by systemic vascular resistance. If you have hypotension or shock, if the diastolic blood pressure is high, it is due to increased vascular resistance. If it's low, it's a vasodilator shock. Now, the pulse pressure is caused by the stroke volume. So when the pulse pressure goes down, the pulse pressure is caused by stroke volume, but the stroke volume here, pulse pressure here is like a gradient above the diastolic. So you have the diastolic like a PEEP in ventilation. If this would be your PEEP in ventilation, the delta P is above the PEEP will give you the PIP. The same here. The pulse pressure above the diastolic will give you the systolic. So the stroke volume doesn't cause directly the systolic. It causes the pulse pressure. And then because the pulse pressure is a sum to the diastolic, it will cause indirectly the systolic. Okay? So this is how we see it. So remember, when you are addressing shock, we will have to look at different types of shock based on the pulse pressure, whether it's narrow or normal. This is first type of shock. This is a patient who was having normal pulse pressure, and you see all three lines going down together. Systolic and diastolic going down together. Since if the diastolic is gone down, by definition, it's a vasodilation. And since the cardiac output is still good and the stroke volume is still good, you get the same delta P above it. So we got the low diastolic, but the PP, which is the delta P, is the same. So the systolic had to go down. So we have same stroke volume, but because the diastolic is gone down, the systolic is gone down with it. I hope you're with me. So this is clearly the definition when the three line goes together down, is a definition of vasodilator shock. And the treatment would be to give volume, to give vasoconstrictor. This is another patient. We see that the systolic didn't move. It's still the same somehow. So the stroke volume is the same. Sorry, so the stroke volume decreased. I'll explain it. What happened here, the diastolic went up. The diastolic went up because there is a vasoconstrictor shock here, vasoconstriction. That went up and so long that at the end, the heart couldn't cope with it, and the stroke volume went down. So now you have the systemic vascular resistance high, causing a stroke volume to be down. So the stroke volume being down, you will have lower systolic blood pressure and it will be narrow. So the PP, the pulse pressure is now narrow, below 15 in a preterm baby, below 25 millimeter mercury in a term baby. So the pulse pressure is narrow. So when I see that the systole didn't go down or remains the same, but the diastole approach to it, which decreased the size of the pulse pressure to become narrow, I would call it vasoconstrictor shock, and my treatment is different now. I need vasodilator or inodilator because the heart here starts failing, like milrinone and dobutamine. Third type of shock, which is the third category. First one, we call it category 1, category 2, category 3. In the category 3, you see the diastolic blood pressure didn't move. It's the same. So the systemic vascular resistance wasn't affected. But because of cardiogenic shock, the stroke volume went down. So above that normal diastolic blood pressure, we created a small systolic blood pressure. So it became narrow blood pressure. So narrow blood pressure with normal diastole is cardiogenic shock, and the treatment would be different. Epinephrine and maybe volume if you check if you need some volume, but in general, epinephrine. So remember, when both go down, when the diastolic go down, it will be vasodilator shock, but both goes down if the cardiac output is good, vasodilator shock. When the diastole goes up, it is vasoconstrictor shock. When the diastole remains good, but the systole goes down, it is cardiogenic shock. It's very interesting that you can, at the bedside, push on a button. Unfortunately, this needs, we don't have every, classically sepsis happen in late onset, and late onsets, we don't have normally arterial line. to get the picture. This is practically when you have UAC or peripheral arterial. I get few cases before I close. The trend, as we said, is used to check the impact of your intervention. This is the picture that I showed you before about vasodilator shock. The patient received 2 volume. He improved a little, but went down back. He received classically dopamine, but dopamine made him worse, or he became worse. Then we see that it's going down, not helping. And then they shifted to vasopressin. And thanks again to Professor Yasser Sayed. These pictures are from him. And then after shifting to vasopressin, it improves. So it allows you to find the effect of your intervention. This is this case which I showed you before, where the diastolic went up, so it's a vasoconstrictor shock. But because the cardiac output couldn't follow, it became narrow. So the treatment is vasodilator, dobutamine, milrinone, and iodulator. This is where this is where he was sick, and then I don't have a picture after treatment. This is this cardiogenic shock. We see that the systolic went down, but the diastolic didn't go up or down. The diastolic because resistance is normal, but cardiogenic shock because systolic is down. So this patient needed inotropes. And so he received epinephrine, and you see quickly that it opened up. This is a case of a healthy, very preterm 23-weekers who was doing well, but borderline blood pressure, and somebody decided to give him volume. So the blood pressure shooted up. There's a risk here of hemorrhage, but it went down quickly without any help. So this is an intervention that wasn't necessary because he didn't have any acidosis and he was doing well in every aspect. Last slide here is about the asphyxia. With narrow, which we see the systolic went down. This is a cardiogenic shock improved with dobutamine. We see it's narrow pressure, 49, 41, 45. Because systolic went down, but diastolic didn't go down, stayed the same. So also this is not, this is out of the scope of my talk, but I think NIRS is essential because you need the client satisfaction survey, and your client is the brain. So this is a NIRS, should be between 60 and 80. And in those monitor at the bedside, you can also request a histogram for the NIRS. And this is a NIRS where it shows that the brain, this is venous saturation, the NIRS. So oxygen consumption by the tissue. And we see that the patient had hyperoxemia to the brain with risk of toxicity in 66% of the time. So this is relevant to know what the brain is doing with what action you've done. So my take-home message is your waves are interesting, and don't get afraid of them. Just go towards them and look at them. You see here, this patient is having periodic breathing here. So histogram also can be funny. You see a slide histogram here and trends. So waves and trends and histograms, this was my talk, last slide. Heart rate trends, plus or minus HERO monitoring to predict sepsis. SpO2 trends to monitor how saturation is happening at any single time and assess the effects of our intervention. Quantify much more precisely than what the nurses put at the bedside about hypoxemia. But more important, the nurses will never tell you about hyperoxemia. SpO2 histogram and along with respiratory rate histogram taken at the same time will help in escalation and de-escalation of treatment. Now, the perfusion index should be checked when you don't have an arterial line to have pulse pressure. You go to the perfusion index, and then it will tell you if you're going towards less perfusion while your shock is improving. So while your blood pressure is improving. The pulse pressure, it can diagnose VDA, but it will help you to decide which type of shock it is and decide the impact of your treatment when you treat, you see also where the trend is going, trend of pulse pressure. Last but not least, blood pressure histogram. You need to target between P5 and P50, not one value like gestational age plus 3, and wean when you are above P50 if you are having inotropes. The blood pressure wave, you can look at it. There's many different waves, but I thought they are not relevant to us as neonatologists. Many ways to look at many diagnoses, but more in adult. So the one that I thought is relevant to us is the pulsus bisfrians to diagnose PDA. And finally, the near-infrared spectroscopy, which is a client satisfaction survey, and our client is the brain. So, as you know, there are so many still unknown, what normal value, depths of desaturation, normal blood pressure, everything, duration, how much it will affect timing, the effect of anemia with hypoperfusion at the same time, hypoxygenation, how to prevent, because we do many things and sometimes it doesn't make any difference. So here it's called the invisible dog. So it's still partly invisible dog, so you don't want to unleash the wrong dog. Thank you very much.
Thank you very much, Faris, for this actually extensive, excellent presentation in a very new field of neonatology. And Donnet covered it in a very well manner, as usual. Thank you very much.
More than 45 minutes, 50 minutes, sorry.
But it was very interesting talk. Actually, need to repeat it again and again until we grasp all the information in there. I have some few questions here. The first question: what is the acceptable histogram for preterm babies on oxygen support more than 25%?
So there is no answer from the literature, but the experts say if you have below 20% desats, it is fine. And then if you have desats down below 85, maybe not more than 15, better less than 10%. That would be the normal for desat. For hypersat, if he's having oxygen, you'd like to keep it as low as possible. It's again the same rule of 20% people are applying based on no evidence, because you know, based on practical, when you are in the unit and you are using those histograms, you see your babies all over the place. Initially, when I established it, I was thinking that I would know whose nurse is watching well the baby and who and what, and I could act on so many things that I would see magic action. But so many patients, we see the histogram very bad, and we do whatever is logic, and we get next day the same bad histogram. Any other question? Hello?
Yeah, we have 2 more questions there.
Thank you.
So the second one: how do we think histogram can help in deciding when to discharge an extremely low birth weight infant from the NICU?
It's a beautiful question. You know, what it does, like I had so many cases. Initially, I didn't use it like that, but now more and more we're using it like that. You have a baby whom you're having 3 liters per minute or 4 liters per minute, and 2 people talk. One of them tell you keep it, one of them say decrease it. So often what we do, okay, decrease it now, please, and do a histogram in 4 hours. And if the histogram is good, keep decreasing based on histogram by 1 liter per minute every so many hours. And then we reach without oxygen at certain level, and then it helps us discharging by weaning. This is the way I would say. We could do more than that. You know, sometimes you have those desaturations that are minor happening during feeding, and you wonder, can I send this patient home with those desaturations happening only during feeding when he's awake? Yes, if you have histogram of NIRS or histogram of you have trends, you find that really is not affecting the baby, and then you might accept to discharge because you know the cause. This will be always partial answered mine, because there is no literature on the subject. There is lots of literature, huge literature on intermittent hypoxia and how much it's dangerous, how much it's risky, but there is not much about how to prevent it.
Question that I requested for some clarification. It was not very clear to me, but I want you to go back first to the very interesting slide, that correlation between the histogram of the respiratory rate with the saturation. If you can go back to this slide.
This I collected. Yeah, I'll find it. Thank you. This is interesting, but in practice, it's hard to. This is the one.
Yeah.
The slide, I took it from an article. I should have referenced this article. I can find it easily because that was an expert opinion in one of the publications. Sorry, I forgot to put the reference. But I modified it a little, but not much. So let's take it slowly then. You have a patient here with no tachypnea, it would say, whenever you have your respiratory rate above 60, between 60 and 80 for less than 20% of the time, they named it no tachypnea. Also, we know it's slightly tachypneic. And the patient who's having it between 60 and 80 only, not above 80 on the histogram also, but above 20% of the time, it's a moderate tachypnea. For those two, you could wean. The second one, because it's more than 20% of the time, you might wean slowly or not wean, keep the same. But because it's only 60 to 80, if it's not, you have to look, if it's not associated with effort of breathing, with the recession, you might see very healthy tachypnea without any effortless tachypnea. Then you might wish to wean even with a tachypnea at 30, 25%, 30%, because you have also the periodic breathing that shows that tachypnea. So you might decide to wean. Now, if you have a patient who's having severe tachypnea above 80 and more than 20%, plus increased work of breathing, for sure you need more support. The problem comes, what do I do? If with the severe tachypnea and there is DSATs, 30% DSATs, especially if a good percentage of them are below 85. So I know that I can increase support, and sometimes if you move the baby up to ventilation, he might be fighting more, and then you might have more DSATs. So here they say to increase the oxygen by 2 to 3%, hoping that to try to capture the upper part of the histogram, but it's difficult because the baby keeps moving from up and down. Those babies are not having only DSATs to increase saturation. Often they have 20, 30% hypersat and 20%, 30% hyposat. So when you increase, you go in the wrong direction. When you decrease, you go in the wrong direction. But this is what the expert opinion said. In practice, you will find it not as easy always to, but certainly the respiratory support itself, you could increase it because the patient's clearly telling you, I need more support. I'm tachypneic with recession or without even recession. Now, when you have less tachypnea, but DSATs, they don't say anything. Myself, I tell the nurses, if the patient is in room air, keep him all the time 23% of oxygen. I am hoping that 23% of oxygen is not dangerous for the eye, especially those babies are usually older. So hypoxemia is more dangerous to the eye. So anyway, 2 to 3%, hoping that it's not putting them at 300 of PO2. It's like walking in a forest. So in those cases, you don't increase support because he's not tachypneic. You keep the same support, and possibly you keep the same oxygen because below 20%, or you might increase by 2%. But certainly this one, I might increase by 2 to 3% if I was room air. And I might increase support if there is some recession. If there is no recession, I wouldn't increase support. So it is not, there is not a clear algorithm where you just say you give this antibiotic. And now this one you can create. I created it myself, but it doesn't mean you can do anything else. It's simple. It's not too intelligent to go and memorize it. Simply say, I will escalate as needed. I will de-escalate not too quickly, and then you create your own process of escalation and de-escalation, especially if you're repeating the histogram after every escalation or de-escalation. I hope I answered the question.
Yeah, great. The question I have now, just to incorporating all the questions together, I will tell you what I'm doing right now to assess respiratory rate and saturation. I look to the histogram now. That's actually something new. Started practicing this from maybe last year or something. But I look also to the monitor graphics. You know, we have the monitor send all the data to the computer digital system we have, and we have graphs. So
Yes.
I look to the respiratory rate trends on the computer. I look to the graphics sent by the monitor to the computer, and I also look to the histogram. So let me give you a scenario, like a baby with chronic lung disease who's in room air, for example, but he's still having tachypnea 60 to 80, less than 28% of the time by the histogram.
Less than 20%.
Yeah, 60 to 80, less than 20%, but he's in room air and there is no desaturation.
So this patient, I wouldn't do anything to him. I would possibly wean. By that expert opinion, you would say
he's not in, he's in room air. My question
is, I will wean the support. I'm saying if he's having room air 3 liters per minute, I make it 2.5 or 2.
No, he's off all support. My question was, is it safe to discharge this baby or no?
I would say yes. I would say after certain, he's been with you because he's chronic lung disease for 2-3 months. So, and you have a history of last week. I would say if you're not doing anything, you're not doing better than the parents at home.
Yeah.
I would discharge myself.
Yeah.
Now, the 20% is too much. It's difficult, you know, when you usually when I have when I have desaturation less than 10% or so, and they are minimal, I would discharge. It's a very difficult question. I'll put it back to you. What would you do? I can't. It's all expert opinion. My words are as same weight as yours and 1,700 people attending now. I would say myself, few desaturation, no big deal. It's dependent. Deep desaturations, no. Like above 85, I don't call it desaturation. I will send. Maybe to desaturating between 90 and 85, and I know the cause, I would send home. Now going below 85, certainly below 80, I don't send home.
Yeah, we, as I told you, in my practice, because sometimes this histogram sometimes is difficult to interpret by itself. Yani I would like to correlate it with the other data that we usually collect. Look at the trends, we look at the graphics in the monitor, like I said. We look, of course, at the patient also clinically, and correlate everything together.
This is why, you know, I put this last slide. You don't know which doc you're unleashing.
It's true. So anyway, we are learning this new practice and trying, of course, to incorporate it to our management now. I cannot think.
At least it's merits that we put time to it and try to learn it. You know, for us, it's amusing to say it's a gift from Corona, because our hospital became a hospital to admit pregnant women with Corona. So we had to buy 20 monitors. So I requested to buy the monitors that allow the histogram. Some of the people have the just previous version that doesn't do the histogram. And now I'm able after Corona to do histogram on every baby. I wasn't able before that.
Yeah, I cannot thank you enough, Faris, for this lovely presentation, and very extensive, and was, as I said, it need to be actually reviewed several times to grasp all the information there. So thank you very much for being with us tonight. And again, I'd like to thank Pearl Management for organizing this event, and thank the audiences who stayed with us until now for this interesting topic. And please don't forget other forums that we always announce for it on the Pearl webpage. We have another forum coming soon, the online grand round, the episode 4, which will be from Kuwait, inshallah. Thank you again, Faris, and you have a good night, inshallah, and see you in our future event. Thank you very much.
Bye-bye. Bye-bye.
Thank you, Professor Tawakkol. Thank you, Dr. Faris. Have a great night.
Thanks.
Thank you.
Bye.
Bye.